Good afternoon, everybody, and welcome to what is really the final phase of our national GIRFT program in pancreatic cancer care. My name is Keith Roberts, and I'm a surgeon in Birmingham, and I'm going to present today with my colleagues who have undertaken the GIRFT work, Professor Dan Palmer, Claire Pearce, Raneem Albazaz, and Ganesh Radhakrishna, and also from thanks to the GIRFT team, Caroline and Katie, who have been instrumental to helping us get to this point. It's been an eye-opening and an enlightening process. It's been great to understand the data, and it's been a privilege to join all of the region's MDTs and colleagues to understand what works well, where the challenges are, and where, perhaps most importantly, we can improve care in pancreas cancer. The process has probably been going for, I guess, nearly 2 years, and it includes an analysis of available national data sets, a deep dive into regions' pathways, processes, treatments, outcomes, and then a review with each of the region's MDTs and teams. We've written a national report which will be released with the conclusion of the GIRFT process, and importantly and usefully in there is also going to be links to best practices, potentially business cases, and how really to help you enable change practice where you see fit. The nature of this meeting this afternoon is the different team members will present the key highlights and their take-home messages from their part in the process, and then we'll have a Q&A session at the end of the session. Can I have the next slide, please? So if I can hand over to Peter from Pancreatic Cancer UK, who will outline their role in this process. Thank you, Peter.
Thanks, Keith. And hi, everyone. I'm Peter DeRosa, and I'm the Senior Policy Manager at Pancreatic Cancer UK, where I lead the policy team. And I guess one of the sort of really key priorities for our organisation over the last couple of years has been addressing variation in the treatment and care that people with pancreatic cancer receive. And we really see that the work that's currently being done by the Getting It Right First Time team, as well as the National Pancreatic Cancer Audit, is really critical to understanding where variation exists across the country, and also critical to driving forward the change that we know we need to see. Next slide, please. So firstly, I'm just going to give a bit of an overview, and I'll talk through the sort of key challenges that exist within pancreatic cancer. So we know there's around 10,000 people diagnosed with pancreatic cancer every year, and half of those people will die within 3 months of diagnosis, with only 7% of people surviving for 5 years, placing this as the deadliest common cancer in the UK, and it's projected to become the 4th biggest cause of cancer-related death by 2026. I guess some of the reasons for these awful statistics are kind of quite simple. The symptoms are really vague and non-specific, and as a result, 80% of people are diagnosed at an advanced stage, and where there's really limited treatment options. And as a result, we see that around 70% of people don't receive any form of active treatment at all. On top of that, people experience complex and severe symptoms and high complex supportive care needs. And we also know that surgery is really the only sort of currently curative treatment option that we have, but only around 10% of people will receive it. So, we have these really intrinsic barriers that exist within the disease, but we know that these are also compounded by sort of significant variation in practice, pathways, and specialist workforce that exists across England. And as a result, we kind of see the NHS at the moment currently isn't really set up to deliver the sort of high quality treatment and care quickly that people with pancreatic cancer need. Next slide, please. So, and we commonly hear all of these challenges and barriers from patients and their families, and they can't, the top challenges they report to us is facing long delays in diagnosis, care and healthcare services not feeling joined up and people struggling to navigate this, and also people feeling like they're having to fight the system due to that coordination and ownership of care. And some of the quotes here on the right demonstrate that. Next slide, please. So kind of recognition of these sort of barriers and this variation that exists across the country. In 2021, we as an organisation embarked on the Optimal Care Pathway Initiative, and we brought together a community of over 300 healthcare professionals and people with lived experience to kind of really understand the obstacles that people face, and agree what needs to happen with the community to improve diagnosis, treatment and care. We undertook a literature review on best practice and guidelines and pulled together a UK-wide steering committee representing pancreatic cancer experts and also people with lived experience. We undertook a consensus building process across all of these experts and people with lived experience to identify the improvements to optimise the management of pancreatic cancer. Through this optimal care pathway initiative that we led, we built consensus on optimal pancreatic cancer pathways and also developed recommendations on how to standardise and drive those improvements. Next slide, please. So that was in 2021. And then since then, we've kind of used the evidence base and clinical consensus to from the optimal care pathway to support the delivery and recommendations that are now coming through in the Getting It Right First Time report and also the National Pancreatic Cancer Audit. So the Getting It Right First Time report, which will be covered today by everyone on this call, will provide a really in-depth review of pancreatic cancer services and the recommendations for change. And then the National Pancreatic Cancer Audit that we have now also provided with a really in-depth understanding of the outcomes for patients in England and Wales that will hopefully allow us to benchmark services and drive the quality improvement that we know we need to see. Next slide, please. I guess looking forward to the next year for us as an organisation, this is still a really key priority area for us, and we're going to be continuing to support local health systems and health professionals to try to drive some of those improvements that are coming out of the Getting It Right First Time report and as well as the National Pancreatic Cancer Audit. And so to achieve that, we're going to be developing a sort of step-by-step implementation guide to support local health systems and healthcare professionals, which will bring together in a really pragmatic way all the recommendations from the optimal care pathway, from the NHS England best practice time pathway, to Getting It Right First Time review, as well as the national audit. We'll also be making a case to government to kind of develop a sort of national optimal pathway across the whole patient pathway based on the recommendations from all the sort of reports that we've had so far. And I guess as well, we'll also be making the case to government through the National Cancer Plan to really underpin all of this with the sort of funding for capacity and workforce needed to implement those improvements across the pathway. Next slide, please. So yeah, that's kind of an overview of kind of our work in this space and the work that we plan to do. If you'd like to be more involved, you can find out more on these links and this QR code, which I'm sure will be shared around afterwards, or please do get in touch with the policy team here, as we're really keen to support everyone, healthcare professionals and healthcare systems to deliver the improvements that people on this call will go on to talk about. So thank you very much for listening. Next slide. And I will hand over to Raneem. Thank you.
Many thanks, Peter. So I'm Raneem Albazaz. I'm a consultant HPB radiologist at Leeds Teaching Hospitals, and I was involved throughout this GIRFT process as the radiology lead. And I'm going to summarise our findings and recommendations with regards to specialist MDTs and diagnostic pathways. So I'm going to start with the specialist pancreas cancer MDTs. So we found these to be really quite widely variable between networks in terms of how the MDT is organised, its composition and its length. How the spoke teams interact with the specialist MDT also varied. So some specialist MDTs were quite cut off and removed from the spoke trusts, and this invariably had a negative impact on the relationships within the network and the flow of the patient pathways. But we did also see many excellent examples of how to streamline the specialist MDT and how to optimize the communication between the hub and the spoke teams. So next slide, please. So based on our observations, these are the main steps that pancreas cancer networks can take to ensure more effective channels of communication between the hub and spoke teams. So firstly, to ensure that all the spoke teams have a representative attending the specialist MDT. So this can be either in person or virtually online. Or alternatively, the specialist MDT should ensure that a member of the surgical team from the hub attends the local spoke MDTs. So both models seem to work, and it's about having that regular weekly two-sided communication. Ideally also to appoint a designated pancreatic cancer lead at each of the spoke centres to act as a clear point of contact, as well as having a designated pancreatic cancer pathway coordinator in all trusts. And importantly, to have regular network-wide meetings. And this is particularly for CNS staff who are often the glue in the pathway. And not just the CNS staff, but also to have regular meetings for all of the HPB staff in the network to ensure regular information sharing and to help develop network-wide pathways. So next slide, please. So in terms of streamlining the MDT, these are the methods that seem to be most effective at the networks that we visited. So having a clear network-wide pathway for dealing with patients that have clearly metastatic pancreatic cancer. These patients can then be managed locally without the need for central MDT discussion. Having other network-wide pathways where possible for dealing with benign disease is also really helpful. So things like pancreatic cysts and keeping the non-worrisome cysts out of the specialist MDT. Minimizing rediscussion of cases. So for example, where a test result hasn't shown anything unexpected, the case doesn't need to go back through the MDT as long as there's a clear management plan that's already been made at that initial meeting. And perhaps most importantly is to try and vet and prepare the cases referred to the specialist MDT beforehand to ensure that the referrals are all appropriate. Next slide, please. So in terms of the patient pathways, trusts need to try and work towards implementing the best practice time pathway targets set by NHS England for pancreatic cancer. So these specify that suspected pancreatic cancer should be fast-tracked in terms of diagnosis and treatment, given how quickly it can progress. So the best practice time pathway dictates that trust should aim for treatment to be initiated within 21 days of diagnosis and 42 days of referral for a suspected cancer. So next slide, please. So moving away from the specialist MDT and looking more specifically at diagnostics, we found uniformly severe pressures on diagnostic services, which isn't surprising, I guess. There are CT reporting backlogs at virtually all trusts. EUS capacity is really variable and waiting times can be problematic, with some centres having reasonable access to deep sedation lists, and these are the type of lists that trusts should be aiming to do. They're the gold standard, and other trusts having no access to them at all. Use of the radiology reporting template, named the PACT UK, which is recommended in national guidance, also was variable, and this was mainly due to lack of radiology prep time and capacity. We found significant problems also in pathology services, with pathology turnaround times being variable due to not only a shortage of pathologists, but also a shortage of lab space and support staff. So next slide, please. So these are our main recommendations to help with these issues based on our observations from the GIRFT visits. So things that we saw were working well in some networks. So introducing rapid access CT pathways for suspected pancreatic cancer to really fast track these patients through, and also jaundice clinics with rapid reporting turnaround times. So in some trusts where this is already being run mainly by CNSs, this approach seemed to be successful in helping to speed up the patient pathway for pancreatic cancer. Combining ERCP and EUS procedures where possible and using deep sedation to increase the rate of successful procedures is also something that we should all be aiming for, because that should then reduce the need for repeated procedures, repeated EUS and sampling. And adoption of the PACT UK radiology template by specialist MDTs. And that should then ensure that imaging information is available in a uniform way for each patient. Cancer alliances should also consider adopting a single queue approach to diagnostic procedures, such as EUS and DRCP, and I'll talk more about that in a second. And in terms of pathology, so Ganesh Radhakrishna, one of our clinical leads, who you'll hear from in a minute, is leading a team to look at the issues in pathology called the The tissue is the issue, and hopefully this will help to streamline the tissue diagnostic processes in the future. So next slide, please. So I just wanted to share a case study on the single queue system from Greater Manchester Cancer Alliance, because we found this really very impressive, and would be fantastic if we could develop this for pancreatic cancer also. So the Greater Manchester Cancer Alliance has developed a single queue diagnostic system across 14 hospitals to optimize some of their specialist cancer diagnostic pathways. So this has now enabled referrers to book diagnostic tests from any of the 14 providers across Greater Manchester in real time, often while the patient is actually still in the clinic. So the system identifies the earliest available appointment from across the 14 hospitals and has the capability to coordinate across multiple modalities. It's been hugely successful in Manchester by reducing variation between trusts. It helps to ensure equity across the kind of geographic region, and it's also maximised the use of existing capacity with really good patient feedback. It's a true exemplar of how we can all organise and run our service. And thinking especially for areas where there are bottlenecks, such as US provision. So that's the MDT and diagnostics in a nutshell, and over to Professor Roberts now.
Thank you. Thank you, Renee. So I'm going to talk a bit about surgical pathways and processes. And as I said earlier, it was a pleasure and a privilege to speak to my colleagues and sit in on the different regions across the UK. Surgical data is really a black hole when we can determine who's had an operation and what the operation is, and we can determine mortality, but we have really very little idea of which patients are being operated on, what their disease status is in terms of is it resectable, is it borderline, arterial or venous disease, and it's a huge challenge even to work it out if patients have had neoadjuvant chemotherapy. One of the clearest differences between units that you can determine from the data is a very wide variation in resection rates for the different units based upon their unit's catchment size. It could be assumed that the higher volume regions just have a higher resection rate, but that's not the case. There is really quite wide variation, as you can see here. The different regions are ranked by their population size, and the resection rate, as shown in green, really varies hugely. And so it's not all about the size of your network. It seems that surgery is an attitude or a function of how the region is working. As we spoke to colleagues, what we understand is various challenges, and as you're going to see throughout this talk, and as Raneem's really nicely shown, it's down to communication, it's down to organisation, and regions that do well have good communication between the hospitals and teams and the networks. Have the next slide, please. One evidence-based piece of practice is the fast-track pathway for patients who have jaundice and resectable cancer. There's level 1 evidence that shows the benefit of this, and yet many trusts and regions have failed to implement the pathway, although following the NICE guidance, several teams do have this up and running, and it's great to see. A pathway that works well is organised by clinical nurse specialists that network across our region. Patients come in, and we don't organise events and diagnostic and staging tests in one after another. We do them in parallel, and we don't wait for the MDT. We review the scan early, and we make a decision about whether it's feasible to do this or not. And we've seen a huge difference in reduction in treatment time, and it avoids cost, harm, and bed occupancy associated with biliary drainage. Can I have the next slide, please? So what we don't know about, and surgery is a technical issue, there are the issues we've spoken about, communication, but surgery is a technical issue, and what is resectable now is in a state of flux in terms of borderline and locally advanced cancer. And what's clear is each unit has their own individual practice. Given the challenges of taking on vascular surgery and this more challenging part of practice, it's remarkable that as a community we haven't organized ourselves to discuss how we can take these patients better on together and be more collaborative and work together to do this. So the use of the PACT radiology template is a fundamental piece of the puzzle. So at least we can understand what patients are being treated at the different organizations. And the other part that feeds into multidisciplinary working is the importance to work with oncologists to realize patients getting through neoadjuvant chemotherapy and adjuvant chemotherapy in a more standardized way. It would be good practice to formalize and define criteria and pathways for second opinion when patients may be deemed unresectable at one region but may be resectable in another. And that would also help generate healthy communication and build relationships between teams and units. It would be useful to identify a dedicated leader within each team who could focus upon driving these strategies forward. And fundamentally, because we can't capture this data in national data sets, there really should be a national registry to do this and to help us inform conversations and identify best practice going forwards. Next slide, please. So thank you. And with that, I'll hand over to Professor Palmer.
Thanks, Keith. Hi, everybody. My name is Dan Palmer. I'm a medical oncologist at the Clatterbridge Cancer Centre and the University of Liverpool. And over the next couple of slides, I'll share with you our observations around the oncology component to the pancreas cancer pathway. So one of the most striking observations was the really quite huge variation in workforce between networks. In the best resourced networks, the oncologist to patient ratio was as low as 1 in 89, but this could go up to 1 in over 350 in the least well-resourced network. And a big component of this was driven by the number of tumour sites that individual oncologists would have to look after, noting that the Royal College of Radiology guidelines recommend a maximum of 2 tumour sites per oncologist, and that HPB should be considered a distinct tumour site. Many oncologists were treating 3, or in many cases more than 3 tumour sites, and this was clearly strongly correlated with the delivery of systemic therapy to patients. And one quite stark example of this is shown here. This is looking at the rates of the use of adjuvant chemotherapy for those patients who underwent surgical resection of their cancer. And we can see the best performing networks had an adjuvant chemotherapy rate of 70 or 80%, but the worst performing networks had rates as low as 30%, and the national average just 50%. And this really isn't acceptable. We know there's a very strong evidence base for the importance of adjuvant chemotherapy in these resected patients. With surgery alone, the recurrence rate is really dismal. And adjuvant chemotherapy has a very strong impact in modulating this. So it's really critically important that patients benefit from the multimodal care in this setting. So this sort of inequality really needs to be addressed. Next slide, please. As well as this inter-network variation, we also saw quite striking variations within networks, and notably patients that were treated by oncologists associated with the surgical hub had much higher rates of delivery of systemic therapy compared with patients treated by oncologists in the spokes. And here we see for patients with stages 1 to 3 disease, nearly 70% of patients were treated at the hub compared with less than 50% at the spokes. And similarly, for those patients with stage 4 disease, 36% treated in the hubs, but less than 25% in the spokes. So clearly unacceptable variation again, and similar patterns in terms of access to radiotherapy, particularly precision radiotherapy, with quite wide variations between networks. And by and large, no clear referral pathways from medical oncology to clinical oncology, such that many patients weren't benefiting from modern radiotherapy techniques. Next slide, please. But really, our major recommendation from the oncology perspective is sorting out the medical oncology workforce and workload to ensure that there's equitable access to expert medical oncology and clinical oncology clinics, with the added benefits that these patients will also see appropriately trained clinical nurse specialists and other members of the supportive team, dietitians, etc. This is challenging. It will require revision of job plans to recognise that HPB oncology is a separate entity, and there will be different models for different networks. Some may adopt a centralised approach, and I'll give you an example of what we did in Liverpool in a moment. Others may require a more networked approach, but with that integrated and clear communication that Raneem and Keith have already described, which will allow the use of common protocols, potential single waiting lists, cross-cover, and access to clinical trial portfolios. Next slide, please. And this is a schema of a proposed oncology pathway. And just to highlight a couple of points, the key, of course, is for ready access to specialist oncology once the specialist MDT is determined that the primary treatment is non-surgical. This would allow that integrated assessment by oncologists, clinical nurse specialists, and other supportive teams, in particular early access to enhanced supportive care and palliative care, recognising the high symptom burden that the majority of these patients experience. For those with locally advanced disease, that access to clinical oncology with clearly defined pathways and to state-of-the-art radiotherapy. And as Keith has alluded to, those on a neoadjuvant pathway need to be tracked very closely and to have two-way communication between oncologists and the specialist MDT so that patients can be reassessed and where appropriate operated on in a timely fashion. So again, highlighting the importance of that integrated approach and involvement with the specialist MDT. Next slide, please. And finally, this is an example of how we managed this challenge in Liverpool. So I moved here in 2012 and recognised that pancreatic cancer was treated in a very devolved and highly variable way. One measure of this was our adjuvant chemotherapy rates were around 50%, in keeping with the current national average. So my approach was to adopt a centralised model where all the patients come to a central HPB medical oncology team, where they can access clinical nurse specialists and enhanced supportive care, as well as access to clinical trials. Where possible, the patients can then be treated closer to home in peripheral units, but have their treatment monitored through the central hub. And this works well in our region. We are relatively densely populated around Liverpool and Merseyside, but also we look after patients in North Wales and the Isle of Man. And the model is still applicable where we see patients face-to-face where necessary, but we'll monitor them remotely and give their treatment closer to home where that is more feasible. This may work for many networks, but not all, and other models will need to be explored. And this is a work in progress that Ganesh will talk about later on. Next slide, please. And with that, I'm happy to hand over to Claire now, who will talk about nursing aspects.
Thanks, Dan. So I'm Claire Pearce. I'm the lead HPB CNS over at Coventry, and I was lucky enough to work on the GIRFT project. So I was looking at the CNS provisions around the country and also the care coordination. So the findings were, we found that there was providers with strong and well-staffed CNS teams, and they were able to achieve better outcomes and overall patient experience based on the National Cancer Patient Experience Survey. Some were able to offer support groups and post-operative support than palliative patients. Some teams, though, however, struggle to even see patients on diagnosis. Well-staffed CNS teams mean that both patients and carers have a much better patient experience. Being well-staffed allows support from diagnosis through to follow-up. We found that CNSs take on numerous roles, so they are able to be navigators, secretaries, dietitians, do benign clinics, have clinical duties and expanded roles, and look after various different specialities, such as just pancreatic, HPB and upper GI, sarcoma, haematology. It's really quite varied. The CNSs, though, need to be able to work within their job roles. So the banding is a huge issue, and people are often working below their banding, which is really not cost effective. CNSs are under a great deal of strain, with 1 in 3 networks having CNSs off on long-term sick leave. Obviously, we're unsure why all of these are off on long-term sick. But for example, in my team over the last year, we've had a navigator go off on maternity in May, which we've only just been able to recruit to this week. CNS has been off on the long-term sick since June, and someone else had bereavement leave for over 6 weeks. This has put great strain on our service here and shows what little teams in little CNS teams can have issues with if people go off sick. And unfortunately, this is not abnormal with what we've seen over the various different networks. However, at the end of this is the patients and their carers and how they're not receiving the support and how the pathway is slowed down because there is reduced CNS figures. So we found that there was a huge variation in the numbers of patients per CNS, similar to the oncologists. So we found that some of them had one whole time equivalent CNS, seeing over 200 new patients per year. And in one network, there was one seeing 39 new patients per year, which is huge difference. Next slide, please. So this graph just shows that the number of new pancreatic cancer patients per CNSs in different trusts can vary greatly. You can see that over 12 trusts have less than 80 new pancreatic cancer patients per year, whereas there are 3 trusts that look over 200 after 241 new patients per year. The difference is shocking and shows that this needs to change. The impact on the patients and their carers is ridiculous in some of the areas. It shows that the work that can be done to support the patients can be brilliant, and in some cases it really is not. So what can we do about it? Next slide, please. So when we look at the recommendations, providers really need to ensure that it's a safe and efficient CNS service. As we've said, the CNSs are the ones that hold the pathway and hold all of these things together. The rest of the team make sure that the pathways running as smoothly as it can, and it's there to support the patients. People need to be seeing all of the pancreatic cancer patients on diagnosis and through their follow-up. And unfortunately, that is just not happening. CNS teams really should be prioritising their cancer patients. I know that there are a lot of varied roles and that CNSs have taken on a lot of sort of benign work, but actually we need to start putting our cancer patients first. And how we can do this is we need to ensure that the admin tasks are undertaken by admin workers, by the secretaries, navigators. If you've got my team's a very good example. I'm a band 8 in my role. A lot of my role of this year has been doing band 4 work because we haven't had a navigator. It's just not cost effective. It's not fair on the patients to be not being supported by nurses because we're having to do the admin stuff. The admin work. So really it needs to be a huge push on the CNSs looking at their services and really pushing to try and see how they can make things work better. If you think about it, the CNSs can generate money through clinical activities, but this is being wasted through chasing scans, appointments, and by tracking patients. Also, patients and carers will reap the benefits of this if we were able to implement it, and it would be cost effective. If we look at a case study, which is the next slide, please. Thank you. So this is from Liverpool, and obviously they have just their pancreatic CNSs, and these pancreatic nurses are able to support the patients and their carers by doing amazing things such as running these support groups. And this is what, although the pathway is really, really important, this is what nurses want to do, and this is what patients want. They want that support, they want that face-to-face support, and we need to be offering it to as many people and their carers as we can, to show that that we care, and actually they receive that amazing gold standard. Thank you, and I'll hand over to Ganesh.
Thank you, Claire. And now, just to reiterate, it's been a privilege to work with this team on this report. My name is Ganesh Krishna. I'm a clinical oncologist in Manchester. Next slide, please. I'm going to really be talking about initially managing pancreatic failure. As you've already heard from everyone, pancreatic cancer is essentially a time-critical disease, but it's also a functional disease, and consequently, many of the patients can decondition quite early on from diagnosis. That what we found from our report is that access to specialist dietetic support was limited, and that can cause further problems during the patient's pathway. As I've mentioned, it can affect deconditioning. And one of the things that we need to think about as a community is obviously not to forget the exocrine and endocrine function of the pancreas, ensure patients are provided with pancreatic enzyme replacement therapy, and at least understand how to access it, and also the association with diabetes, which is quite critical, and ensuring that there's support for that. Next slide, please. So what we have recommended is really and I think we've seen this throughout the presentations, is access to timely access to improving patients' quality of life and dietetic support. We do need specialist access, and that's a theme I think that we've been hearing a lot today. So we need to protect the HPB dietitians to ensure that they can provide that comprehensive care for what is a complex disease and caseload. The funding needs to be associated with surgical and oncological or non-surgical services as well. As we've already heard, the majority of the patients will probably be going down a non-surgical route, and so there needs to be some consideration about how we deliver pancreatic support for our patients across the whole pathway. Trusts can provide support with non-specialist dietitians, but that does sometimes require a little bit of extra support for these individuals. And as you can see on this slide, there is quite a lot of information out there that we can signpost to. There needs to be a very early and timely review of patients in terms of their diabetes control very early on in the pathway, particularly if they're going to have further treatment, in this case, from my perspective, in oncological treatments. And so having access to specialist diabetic services with knowledge of type 3 diabetes is essential. And also having a high index of suspicion with patients presenting with symptoms that may correlate with diabetes. Next slide, please. We've heard Peter say this already. Pancreatic cancer has got a very poor survival. It's projected within the next year to be the 4th biggest cancer killer. And so it is part of that comprehensive care that patients should have early and timely access to supportive care or supportive oncology. Half of the diagnosis are patients with metastatic disease, and we do recognize there's a shortage of palliative care provision across the country that compounds access. However, there are exemplar models where early access to enhanced supportive care, particularly for pancreatic or HPB patients in this situation, can improve patients' quality of life, but it also reduces elective admissions, length of stay, and also A&E or emergency admissions. This is a really not just a financial benefit, but it's also very important for the patient and their families as well. Next slide, please. And so our recommendation is to ensure that all cancer centres have equitable and timely access to enhanced supportive care or supportive oncology patient services for patients with pancreatic cancer. And there should be really an early or reactive referral process. So patients aren't waiting to develop symptoms. They are referred very early on the pathway to access supportive care, because this may actually help in terms of improving the outcomes and also supporting the patients so they don't decondition in the pathway and can access oncological treatments. Next slide, please. I think this is probably the same message in that it is about ensuring optimal and rapid access to patients for patients to enhance supportive care. Next slide, please. And finally, I think one of the things that we did come across as we were doing the GIRFT report was issues with the coding and data, and it is really important that we all take a collective responsibility and accountability for the data, because that's what we need to improve outcomes and continue to do so. And so one of the key actions that we would recommend would be to have key metrics within the model health system to improve existing data collection, supporting trusts to conduct local audits as well, to corroborate, as well as to ensure that the data that we're getting is as accurate as it can be. And we do need to invest in data managers. We are, it's what data-driven practice is all about. And also, cancer alliances should benchmark against the available current recommendations from the National Pancreatic Cancer Audit, GIRFT, Best Practice Time Pathway, and the OCP. Next slide, please. One of the things that we recommended and we were successful in pursuing has been to shine a deeper light or a greater light on the oncology services. And that is what we're currently doing between Professor Palmer and myself, where we're visiting all the cancer alliances and looking specifically at the HPB oncology provision. And this is really to get a bit more granularity and detail on how HPB oncology is delivered across the networks, but also to try and bring the message that we've been trying to get across with this GIRFT recommendation to all the alliances and to all the oncology services, that HPB oncology is a designated specialty. We need to ensure that patients have timely access to good, high-quality oncological care, and patients are followed through the whole pathway and supported adequately for what is a very challenging cancer site. This is ongoing, so we will be going around all the cancer networks. And next slide. I might hand over to you, Dan. So I think this is, yeah. Thanks.
Sorry, did you want to say anything else before we open to Q&A?
No, that's great. Thanks. I'll hand over to you. Thank you, Dan.
Thanks, Ganesh, and thanks, everybody. Hopefully that's given people an overview of our findings and recommendations for the GIRFT report. Please do keep your questions coming in. We've got a few minutes just to address some of those. The first from the audience, a really important question. In the interest of time, we didn't really touch upon it, but really talking and asking a question about the upstream part of the pathway, and obviously the key to really making an impact on pancreatic cancer is earlier diagnosis. all too often our patients present in a very symptomatic stage, often through A&E, where best supportive care is the only appropriate treatment. So we really need better efforts on earlier diagnosis. We saw some good examples of that in our reviews that you will find in the report, particularly from Guildford and the Royal Surrey team. Work that we do in Liverpool is related to new onset diabetes, and Maneem, you might have something to add there in terms of that being an appropriate trigger to CT scan if there's suspicion that that diabetes may be related to pancreatic cancer. Family history and genetics are another potential group that could be identified better in terms of at-risk families. Panel, any other observations on how we might improve earlier diagnosis? Peter, any thoughts from a PCUK point of view?
Yeah, thanks, Dan. And I completely agree. Like, it's one of those things where we need to both address the pathway improvements through this work, through the Getting Right First Time program, but also at the same time address people's improving access and referral into the system, both for people at risk, but also people presenting with symptoms. And as Dan kind of alluded to, NHS England have done a lot of work over the last couple of years trying to improve access, trying to get more people into the system. So they've launched in June, they launched the case finding pilot, trying to find cases of pancreatic cancer in people with a recent diagnosis of diabetes and weight loss over 60. And they've also recently put investment into trying to improve access to surveillance for people who have inherited pancreatic cancer risk or hereditary pancreatitis. So yeah, it's two big pieces of work that NHS England have been looking at. So yeah, there's a lot going on in the space, but there's obviously much more we can do, and there's also a lot more research to be done as well.
Yeah, hugely important area. Claire, a question for you in terms of the CNS workload and how that varies between hubs and spokes.
I mean, it does. It varies loads, and obviously we see that there's we said HPB CNS is HPB upper GI. Some of them do surgery, some of them just do oncology, and some of them do surgery and oncology. And it's about everyone assessing their service and seeing what it is that they can do to make it safe at work. It's really difficult to actually put into words how we can figure this problem out. It's just too vast, and obviously lung have done their GIRFT project, but they only had just lung, and obviously in ours it's very different because it's pancreatic cancer and pancreatic and sort of HPB upper GI, so it's really difficult. But it's about the CNSs having to look at their services and see what it is that they can not do that they are doing, and then what it is that they can do with, like I said, the admin side of things to really sort of make a massive difference in their CNS teams.
Thank you. And you talked about the Liverpool model that our wonderful specialist nurse Phil Whelan coordinates. What are the barriers to that being more widespread, do you think?
I think the biggest barrier is the staffing levels. Obviously, we've seen in the trusts that have got these amazingly staffed CNS teams that they can do sort of tea with the team and do these lovely support groups. And then we've got the lone CNSs that don't even get to see patients on diagnosis. So it is looking at the staffing levels and trying to figure out how that can be improved. And obviously with the group work and stuff like that, it is, like I said, dropping things that CNS teams don't have to do, and I think that will make a massive impact. It's not going to cost a lot of money to run these things. It will literally just be trying to find a room in your local trust. I know some places don't do that. They've been able to work it with sort of different areas and be able to get rooms if they can't get one in the trust. So it's about being a bit clever with how you can get the rooms. Even some people do some charity work to be able to get some money to be able to get the rooms and refreshments and stuff like that. So it's just about thinking a bit cleverer and out the box to try and get these services implemented in your local trust.
Yeah, thanks, Claire.
Thanks.
Just thinking about the diagnostics end of the pathway. Raneem, you mentioned the PACT UK reporting tool. Do you see what are the barriers and the opportunities to implementing that? Any thoughts that you could expand upon?
Yeah, thanks, Dan. Well, so we've used PACT UK now in Leeds for a few years. We were involved in kind of putting it together, as well as many multiple other centres, and we found it a really positive step in our MDT, and now our surgeons expect it and ask for it all the time. And I have to say, kind of to begin with, we all had the same worries that it may be more time consuming. We may have to spend longer looking at each case, filling in this very prescriptive template. But actually, when it comes to using it, that's not the case at all. It doesn't really add any extra time. We only use it on a handful of patients per MDT because it's only really for those that are potentially suitable for resection. And it's really good because it ensures that all the data points that our surgical colleagues need are all available in one place in a very clear, consistent way for each patient. So actually, it makes us into better radiologists, I would say, because we're having to really analyze everything in a very consistent way. So overall, it's been a very good step, and I would really encourage everybody to use it, for all MDTs to adopt it. And it's only to be used by the MDT radiologists when they review the case, fill in the template. And I think once people do start using it, they'll realize it's not as time consuming as they think, which is the main barrier, is this assumption that it'll take longer.
Mm-hmm. Yeah, and I think in terms of standardized approaches, particularly around borderline resectable disease, to be able to compare our data in that much more systematic way is really important. So I would strongly encourage people to get involved and use it, and hopefully become familiar and become beneficial after that initial learning curve. Thank you. Whilst we're at that diagnostic end of the spectrum, a question around EUS and ERCP, and for those with obstructive systems, should the combined procedure now be considered standard of care? Any thoughts from the team?
Well, I can start. I think, yes, ideally, where possible, a combined procedure. The reason being is that you can drain the biliary system and also get the biopsy, or have a better chance of getting the tissue diagnosis all in one sitting. And that then should speed up the rest of the patient's pathway. You'll get the diagnosis more quickly rather than having to have repeated procedures. We know that EUS FMB gives the best yield of tissue. I think the success rate is over 90%, whereas it's much lower for just doing biliary brushing via ERCP. So ideally, combined EUS and ERCP, and ideally to have this available as deep sedation list where there's anesthetic support as well, again, should increase that yield of that first biopsy being diagnostic and the patient not needing repeated procedures.
Yeah, absolutely agree. Again, we saw consistently that pathology was a scarce resource across the majority of networks. And as with many of the challenges, it's an issue around staffing. We need more oncologists, we need more CNSs, we need more pathologists in general. Maybe technology will help us. A question from the audience around the utility of circulating DNA as a diagnostic tool. I guess at this stage it's considered research, but any thoughts from anyone about how that may become mainstream? Some very nice data coming out of Noreen Starleen and the Marsden. Are we close to prime time, or is this still too far away?
Shall I come in on that, Dan? I think it'd be great to sort of see the data accumulate and try and find a way where potentially we can integrate it into the diagnostic pathway. And I guess this is part of what we're trying to do with the tissue, is the issue discussion as well, in terms of optimizing how we can optimize the diagnostic pathway and speed it up. So I think I'm not sure if it's prime time yet, but it's got a lot of promise, and hopefully we'll be able to accelerate diagnostics. It's just probably needs to be integrated more into more study and also into the pathway for us to analyze further, I think.
On a slightly related note, and jumping on the bandwagon of AI, many of you will have heard on Radio 4 this morning Peter Johnson talking about AI-assisted colonoscopy. Renee, any thoughts on how AI may help unburden the backlog of radiology, and any hope or scope or fear for the future?
Probably all three, to be honest. Yeah, there's definitely hope. I mean, there's an incredible amount of work going on at the moment in all fields of radiology with AI. And I mean, obviously we start with the simple things, with x-rays, chest x-rays, and it's already, proving to be very helpful with that. So yes, I think down the line, I don't know the time frames, who knows, but there will be some radiology work, routine radiology work should be kind of removed from our work, and that it'll be done by AI, and that will give us hopefully more time to look at the complex things, to spend more time looking at complex pancreatic cancer cases, being able to report them more quickly. But yes, I don't know where this will go down the line in terms of being able to distinguish, between pancreatic cancer, inflammatory change, that kind of thing. It's all in very early stages when it comes to pancreas at the moment with AI.
Thank you. A question for you, Claire, if I may, from the audience. Is there a recommended minimum number of CNSs per HPB service?
No. So with the NHS working under significant operational financial practices, oh, hold on a second.
That was a good way of dodging the question.
That's significant work pressure. She had to go and sort out some patients for it.
Yeah. Sorry, that was one of my team members left their Teams chat on and left. Yeah, so no, we weren't able to put the recommendations in. We have got a statement about it, and I think that Katie's put that in the chat for us.
Thank you. So a question to you, Keith. I talked about how we've centralised oncology services in Liverpool. Of course, the surgeons did that 20 years ago, recognising that with the skill and the aftercare required to get people through a Whipple's requires that volume and that expertise, and the benefits were tangible in terms of surgical outcomes. We've demonstrated something similar with oncology, where our adjuvant chemotherapy rates went from 50% to in excess of 90% through centralisation. Is this something we need to be bolder about? Should oncology be centralised in the same way as surgery, or do we need to look for alternative models? Any thoughts from the team?
Well, thanks, Dan. I think there are benefits and downsides to centralised oncology service. You've clearly shown that it works very well in your region, and you have the highest rate of adjuvant chemotherapy, and so the proof is in the pudding. I think the challenge to reorganise oncology services like that, particularly at this time, it is huge: cost, resource. A huge step in that direction is to, and I don't know if the oncologists do this already, but to formalise a local network, get together and have regular meetings, share data, talk about. Surgeons always ask for neoadjuvant chemotherapy. You'll have a lot of oncologists particularly in the secondary care sites, still calling it palliative chemotherapy. And that may be a reflection on surgeons not translating that into an operation at the end of the pathway. But there needs to be more communication and closer working to achieve that, would be my.
Yeah, thanks, Keith. I think that's hopefully been a very clear message today, is that communication is key, whatever the model, particularly with the constraints that we're working under. Unfortunately, we've run out of time, so apologies if we didn't get to your question. Thank you all for your attendance. Thank you to the panelists for sharing your thoughts and your expertise. It's been a pleasure and a privilege working with you. If we didn't get to your question, hopefully it will be covered in the report, and the links have been posted in terms of how to access that. So thank you once again for your attention, and have a good day.